Good morning, everyone. Today we are going to discuss about the management of pulmonary hypertension. What is new in the management of pulmonary artery hypertension, and what its implication for clinical practice. Just we'll go through the brief in pulmonary hypertension. It is a major contributor to the right heart failure, as we are knowing. And if you look at the 80% of population with pulmonary hypertension, is from the developing countries. The major prevalence and incidence is noticed in the southeast countries as compared to the western countries. So if you look at in India, the annual incidence of pulmonary hypertension in Kerala registry, it was 48 per million adult population. Now come to the updated definition for pulmonary hypertension. In 2015, ESC and ERS guidelines, which for the pulmonary hypertension, they have characterized the mean pulmonary artery pressure more than 25 to define the pulmonary artery hypertension. But in recent guidelines, they have changed to the more than 20 millimeter of mercury mean pulmonary artery pressure to diagnose the pulmonary hypertension. It can be pre-capillary pulmonary hypertension if pulmonary artery pressure mean more than 20 and pulmonary wedge pressure less than 50 and PVR more than 2 Wood-Chinese. If it is post-capillary pulmonary hypertension, then pulmonary wedge pressure more than 50 and PVR less than 2 Wood-Chinese. Now comes to the evaluation of the PAH treatment. There is a significant progression in treatments. If you look at the 20 years and 30 years ago, there was no treatment for pulmonary artery hypertension. And today there are the 13 treatments for the pulmonary artery hypertension options are available. And definitely that has changed the era which was shown in the real registries that over the period of time, the established treatment has drastically improved the survival from the 3 years to the 9 years after the diagnosis of pulmonary artery hypertension. And we know that the key pathways involved in pathogenesis of the PAH is endothelin pathways, which causes the vasodilatation and antiproliferation. So we have a stimulant of these two pathways, which is helpful in the treatment of pulmonary artery hypertension. Now, these are the most 8 determinants of the prognosis of the PAH. First is progression of symptoms. Second is syncope. Third is Bruce functional class. Fourth is 6-minute walking distance test or exercise testing. Fifth is natriuretic peptides, imaging including echocardiography and cardiac MRI, and hemodynamic about the right heart catheterization and right heart failure. So these are the 8 determinants of the progression of the pulmonary artery hypertension. And this is the treatment chart algorithm for the pulmonary hypertension. What this is, treat the PAH patient as much as you can do aggressively as possible. So suppose the patient who comes to the clinic when the PAH is confirmed by expert center, mainly by the right heart catheterizations, you can give some general use, some supportive treatment. Then these patients are for the vasoreactive tests, only for the idiopathic, hereditary and drug-induced pulmonary artery hypertension. If vasoreactive is confirmed, then these patients can be treated with the CCB, calcium channel blocker. Suppose patient is non-vasoreactive, then you have to classify whether it is low, intermediate or high risk. If it is low risk, you can give the residual role of the initial monotherapy, either with endothelin receptor antagonist or PDE inhibitors. But if patient suppose in intermediate risk or high risk, definitely you have to start the initial oral combination therapy. After the 3-6 months, you have to reassess the patients. If still patient is falling into intermediate or high risk, you have to give the triple sequential combination therapy. Still patient is not responding, you can maximize the medical therapy and you can give an option for the lung transplantation. So this is the algorithm. The most important things start with the oral combination therapy. If you look at the ERS PAC guideline 2015, the recommendation for the initial combination therapy is class 1A in patients who is having a functional class 3, and class 1 recommendation for patients with PH, it's embryosartan and tadalafil combinations. Other ERA plus PD5 inhibitors, they have a class 2A recommendations. So it is important to initiate the combination therapy, specifically embryosartan with tadalafil, as in function class 3, it has a proven role and it delays the progression and it improves the symptoms of the pulmonary hypertension. Now, which was the trial which has shown that ambition trial, they have shown that initial combination therapy with embryosartan and tadalafil significantly reduced the risk of the clinical failure by 50% as compared to the pooled monotherapy with either agents. So, if you give the combination therapy and you feel compare the individual molecular with the pooled monotherapy, the advantage is more with the combination therapy. It will reduce the clinical failure by 50%. This was another repair study which has studied the mesisantan and PD5 inhibitor, which has shown over the period of 26, it reduced the RE size, it increased the LV size, and it moves the septal from left to right, which reflecting decreasing right heart side pressures. Now, what are the challenges in management of pulmonary hypertension? As we are knowing that once the patient having a PAH, it is always progressive and it is associated with high mortality and morbidity despite of available treatment. As we know that PAH is incurable disease, it progresses silently even if patient feels fine with therapy. This is the 3 registry, Triton study, Seraphim study, and Ambition study, which has shown that 20 to 32% of progressions despite of dual PAH therapy. So, what are the options we have once the patient's on oral combination therapy? So, this is the new molecule which ERS and ESC guidance recommends the Selexipeg add-on therapy on background of the combination treatments, specifically patients who's having an initial, intermediate or high risk. So these are the patients will get the benefit of the triple sequential combination therapy. So how will you classify the patients with the low, intermediate and high risk? So this was published in 2015, which ERS and EST guidelines has classified into 3 strata: low, intermediate, high risk, based on the risk assessment, which involves these are the 8 components. But this is very cumbersome. You cannot apply for the routine clinical practice. And so what they have changed, they have simplified the 4 strata risk assessment tool, which is newer one, which was published in 2022 ERS ESC guidance. They have just take the determinants of the point rules, function class, 6-minute walking distance test, and BNP or NT-proBNP. So it will classify it into 4 assigned point, 1, 2, 3, and 4, depending on the low risk, intermediate, high risk, or high risk. So what is the advantage of this 4 strata risk assessment tool? It is compared with the 3 strata model. The 4 strata model is more sensitive to changes in risk from the baseline to follow, and these changes were associated with the changes in long-term mortality risk. The main advantage of this is better discrimination between the intermediate risk group. It will classify intermediate low risk and intermediate high risk, which helps the guide to therapeutic decision making. So now come to the Griffons trial. What we are going to discuss about the Selexipeg. This is a Griffon trial which is recently published, which have studies the treatment need or patients who's already on the endothelin receptor antagonist and phosphodiesterase 5 inhibitor combination or monotherapy. So they have studied the 1156 patients and they were randomized into 1:1 ratio. The 50% of patients has received the Selexipeg from 200 to 1600 microgram twice a daily dose as compared with the placebo. The primary endpoint was time to first morbidity and mortality event. But they have studied the disease progressions, hospitalization for PH worsening and worsening of PH and all-cause death. If you look at the patient's profile, the etiology of PH in which 58% was having a idiopathic or hereditary PH, 29% of patients was having a CTD, means connective tissue disorder related PH, and 10% of patients having a congenital heart disease related PH, and whose function class was at baseline was class 2 and class 3 in majority of patients. It was multi-center double-blind randomized trial, and there were almost 32 persons was on only phosphodiesterase inhibitor and 15% was enterothelial receptor antagonist. So this was the baseline patient's profile. What they have shown that Selexipeg reduced the risk of morbidity and mortality by 40%. If you look at the bar diagram, the overall proportion of patients was lower found in triple combination therapy, was 27% as compared to the dual anti-therapy, anti-PH therapy, which was 41%. So there is overall 40% risk reduction, and p-value was very significant, and hazardous ratio was favorable for the Selexipeg. Not only that, it also reduced the hospitalization and death due to the pH worsening by 30%. So this hospitalization was lower in Selexipeg group as compared to the placebo. It also improves the 6-minute walking distances from the baseline to 26 weeks. So at the end of 20 weeks, the 26-week therapy, the improvement of the 6-minute walking distance was changed up to the 12 meters in Selexipeg group. And this is about the patients who is having a connective tissue disorder with the PH. There is a 41% reduction in events in terms of mortality and morbidity if patient is treated with Selexipeg with the combination of the anti-PAH. So, systemic sclerosis, SLE, multi-connective tissue disorders, in which if you treat with the triple combination therapy, definitely patients have a more advantage of the Selexipeg in background therapy of the anti-PH therapy. So, depend on that, the ERS ECSC guidelines recommending the triple combination therapy or triple sequential combination therapy for PH in patients who's having a function class 3. The Selexipeg with ERA or PDS inhibitor is class 1 recommendation. So when we should add the Selexipeg and when we'll get the maximum impact in clinical outcome. So this was the study when you add before the 6 months of the diagnosis of the PH, and if you treat after the 6 months of the diagnosis. So patients who has received the Selexipeg within the 6 months of the diagnosis of pulmonary hypertension, they have shown that there is a much more risk reduction by 55% as compared if you treat the patients with the Selexipeg after the 6 months of the diagnosis. So it is very important to initiate the Selexipeg therapy as early as possible in after the diagnosis of pulmonary hypertension. And this is also seen that treatment effect is greater when initiated early in the course of the disease. So if you look at the patients who is having a functional class 2, they will definitely get more benefit of the Selexipeg therapy in background of the other anti-pulmonary anti-PH therapy. So what is the treatment impact of Selexipeg when used as an upfront triple combination therapy? So this was a Triton study where they have studied the upfront triple combination therapy with Selexipeg. Means one patient will receive triple combination directly and one patient will receive the double combinations. And if you look at the bar diagram, that first disease progression event and all disease progression event was quite lower in patients who has received the triple oral combination therapy. The worsening of the pH, hospitalization for worsening of pH, and initiation of prostacyclin for pH and all-cause deaths was lower in patients who has been treated with the triple combination therapy. So initial triple therapy adds the incremental benefit over initial double therapy for the further delaying disease progression. So in high risk of patients, definitely triple combination therapy is very much beneficial And this is the case report which has been published in European Heart Journal in 2020. And this is under combination of therapy, Selexipeg, Mesicenta, and Selexipeg has shown that there is a significant hemodynamic improvement in terms of cardiac MRI, where there is a improvement in RV ejection fraction and there is a improvement in RV systolic volume index. And maximal advantage dose when you treat with this patient with the high dose. Almost 64% of patients receive the high dose, means 2000 microgram per day. And they have shown there is a significant improvement in pro-BNP levels, move functional class, and the mean pulmonary artery pressures. So these are the other medicines which are available to treat the patients with the high risk PAH. When the patient is not responding with either ERA or phosphodiesterase inhibitor, this is epoprostenol, we can use IV. This is the allopros, verapros, and treprostinil, which has inhalation and sub-Q and IV administrations. And last is Selexipeg, which is available in the oral form. The maximum advantage which is available in oral form, so patient's compliance will be good, and compared to the other therapy, it is cheaper. What is the benefit of using Selexipeg? Because it is a highly selective IP prostacyclin receptor agonist. So it has metabolite has a higher affinity for the IP receptor compared to the prostacyclin receptors. So it is associated with the fewer adverse effect as compared to the other prostanoids. And as we know that this headache, diarrhea, nausea, and pain enjoy this common side effect with the prostacyclin therapy, but once the patients on the Selexipeg therapy, the maintenance dose will have a less side effect as compared to the initiation of therapy. So maintenance dose is highest tolerated by the patients. So comes to the key message to the use of Selexipeg. It is a novel, orally available, and highly selective IP receptor agonist. There is a significant risk reduction noticed in death and complication related to the PH by 40%. It reduces the stress on the heart by reducing the anti-proBNP level, improves the 6-minute walking test and boosts functional class, achieves the low risk status mortality from intermediate risk. So early initiation with Selexipeg has a greater impact on reducing PH progression, hospitalization, and reduction in enterocrine. It is safe and well tolerated. Thank you.